So this is a case, Kevin started the PowerPoint presentation and then he found out he needed to be in the OR. So I finished it and then I'll be presenting it today, hence why both of our names are up there. So we'll go ahead to the history. So we have a 48-year-old female who works as a psychiatrist. 3 days ago, she woke up with blurred vision inferiorly in the right eye. She saw someone over the weekend and the right optic nerve was noted to be swollen. She does not have any pain with eye movements and the left eye is okay. Medical history is notable for migraines and surgical history notable for LASIK about 10 years ago. Her systemic meds are Mounjaro, the generic is tirzepatide injections Q weekly, Prozac, Nexium, and sumatriptan. Her distance vision in the right eye is 20/20, in the left eye is 20/16, and her IOP is normal.
Okay, so here we have a fundus photo of the right eye. The media looks clear, vessels look good, normal caliber. Attention's drawn superiorly to the optic nerve, where you can see a significant blurring of the disc margin there, as well as blurring of the vessels, kind of continuing on all superiorly, a little bit inferior, but not quite as severe as superior temporal there.
Yep, definitely.
And then here is a color fundus photo of the left eye. Media is clear. Vessels normal caliber. Still kind of a small disc here, it looks like. So kind of a disc at risk, but more not quite as so defined borders here.
Perfect. These numbers may be hard to see, so if you can't see them, I can definitely read them out.
Not really.
Okay, sure. So the RNFL thickness in the right eye is 191, and then the left eye is 94.
So significantly thicker and elevated in the right eye. Okay, so here is the OCT of the right eye. So good foveal contour here. Looks like the retinal layers are nice and sharp. And again, attention is drawn over here to the nerve, and you can see it's significantly elevated. I'm not sure, kind of right, a little bit right near the nerve, if that is some subretinal fluid starting or if that's just some shadowing there. Here is a OCT of the left eye. Again, good foveal contour. Retinal layers look good. Over here, the nerve, it does kind of look elevated as well. But again, if it's a small cup, it can kind of look a little bit elevated, but looks elevated as well, slightly. Okay. Ooh, we got a visual field. So
we have a machine. It's really old, but we have one. Like a dot matrix printer.
Okay. So I'll start with the right eye. So at the right eye over here, you can see they have an inferior visual field loss, kind of significant. And then on the left eye, it looks like a pretty clear visual field. And they look like reliable tests. No false positives, no false negatives, only one fixation loss there in the right eye. So they're a good test taker. So, okay.
Oh, go ahead.
Sorry. Oh, sorry. I was going to read it, but it's okay.
Yeah, go ahead.
So yeah, case summary. She's just a 48-year-old female who had a history of migraines and woke up with inferior visual field loss out of the right eye with preserved central vision. And then the DFE and fundus photo showed segmental optic nerve edema with flame hemorrhages and a small cup to disc in the left eye. And then OCT shows elevation of edema of the optic nerve. And then that visual field shows that altitudinal defect, which corresponds to the superior swelling that we saw. So some of my differentials, since it is unilateral, she does have a disc at risk and she's on the tirzepatide. NAION is kind of top of the differentials. She's pretty young, but you could still consider something like giant cell, any type of infectious etiologies for swelling like Lyme, toxo, syphilis, anything like that. IIH would usually present bilaterally, but still something to consider in a female.
Yep, so that's a great differential. So on this slide, there are a couple different, mnemonics you can use to help remember different kind of etiologies for a specific finding. So for optic disc edema or just generally optic neuropathy, I have a table here coming up from BCSC. So here, just listing a couple different general categories, and then I have the table here. So papilledema, certainly it could be kind of asymmetric in one eye more so than the other. Can certainly be glaucoma if you're more so seeing the pallor component. Inflammatory diseases, optic neuritis, NMO, MOG. Vascular conditions, ischemic optic neuropathy, radiation optic neuropathy, compressive lesions, a hemorrhage, intracranial hemorrhage. Hereditary conditions, toxic substances. We always classically think about alcohol, and then nutritional deficiencies, B12 and folate deficiencies. Trauma, congenital causes, and drusen. So our patient had ischemic optic neuropathy. And so I feel like we all kind of know the different categories at this point for ischemic optic neuropathy. So we have posterior ischemic optic neuropathy if it's affecting the retrobulbar portion of the optic nerve. And then we have anterior ischemic optic neuropathy, which is more so compromise of the optic nerve head. Both can be further classified into arteritic, which is like giant cell arteritis, and non-arteritic, which does not have that inflammatory component. So this slide here just shows the vessels a little bit closer. In terms of NAION, it is the most common cause of acute optic nerve disease in the elderly. It's called non-arteritic because there's reduced blood flow without true inflammation of the blood vessels. The annual incidence is about 2 to 10 per 100,000. And so there are about 6,000 new cases each year in the US, which I feel like we see a big chunk of those at TGH and at the VA. And the mean age is 60 years old. So another slide in terms of the pathogenesis. Pathogenesis isn't completely elucidated at this point, but the prevailing kind of thought is that it's considered like a compartment syndrome of the optic nerve head. So especially if someone has the crowded disc or the disc at risk, it can happen more commonly. So if there's hypoperfusion of the short posterior ciliary arteries, it can result in an ischemic injury, resulting in optic nerve head edema. And this reduces the kind of space of the optic nerve head. And so you have compression of axons and then death of the ganglion cells. In terms of how the clinical presentation can change in the acute stages versus subacute, and then the more kind of later and chronic stages, in the first 6 weeks, you're seeing the hyperemic optic nerve head edema overlying a small cup, and then the other eye will certainly show a small cup to disc ratio. And then we often see it more so in the superior or supratemporal portion of the optic nerve head. And then the later stages, the optic nerve head pallor is more prevalent from then on. Another slide just showing the progression of the disease. Again, the initial kind of 6-week period, more so seeing the edema, the hemorrhages, and then later on the pallor.
And I don't know if you mentioned it, but it's very common for people to get worse the first month. It's like an enormous number of people present and then worsen. And it gets them very nervous because they think maybe something else is going on, or I have those numbers. I'll try to find those numbers. So if someone does present with optic neuropathy, it's nice to tell them. It's nice to manage expectations. So it's not uncommon to get worse before you get better. I think it's a time.
You see that more so with like visual acuity. You see the visual acuity decline a little bit more.
Yeah, vision, symptoms, shadows, everything kind of drops. And yeah, David said a third. I have it somewhere on my phone. I'll tell you in a minute. But keep going.
Okay, so this table here compares arteritic versus non-arteritic. I feel like we definitely know these kind of differences now. So in terms of age, it's a little bit of an older category and more so in females than in males for like giant cell arteritis. compared to NAION, it's usually around 60, and it can affect men and women equally. Symptoms of giant cell, headache, scalp tenderness, jaw claudication, amaurosis fugax. And then in non-arteritic, it's usually that case where someone wakes up all of a sudden and just notices their vision in the kind of altitudinal defect has been affected. In terms of the optic nerve head appearance, the hyperemic optic nerve head edema and the small cup-to-disc ratio more common in non-arteritic. And then pallid optic nerve head edema, we think of GCA or arteritic, AION more so. Okay, so supplemental testing, you don't necessarily need to get these, but it can help kind of confirm your diagnosis. So OCT, you could get an RNFL thickness. You can also look for peripapillary edema. Humphrey visual field can show you that altitudinal defect very well. When we're, in the emergency department, we're usually just doing confrontation visual fields, and it's a good kind of initial test. And then FA can show that delayed optic nerve head filling. No real treatment for NAION. Our best kind of solution is to control the medical risk factors to optimize those. So blood pressure, diabetes, hyperlipidemia. If a patient has not yet been diagnosed with OSA, it would be a good idea to have them get a sleep test, hypercoagulability, anemia, and then medications. So PDE5 inhibitors classically, and then with our patient, she was on a particular medication, the Mounjaro, which I will go into a little bit more coming up.
The thing is, there was the optic nerve decompression trial, which was negative. So it's interesting with the compartment. It does seem like it's a compartment syndrome. So it seems like if you decompress the optic nerve, it might help. So there was a trial where people went in. Your dad was probably in it, where you went in and you cut a hole in the optic nerve sheath acutely in these patients to try to decompress it. And some of the surgeons, there's a surgeon in town who's a very good surgeon, felt like he still felt it was effective. He felt like it was a very difficult surgery and it really didn't get a fair trial because you really needed to,
Freiberg was the one who debunked it.
Debunked it.
Yeah,
So
Pittsburgh, yeah.
So anyway, but it was an interesting thing. You would go and you would just cut a little, it was technically possible, although challenging. But it was a negative study.
And so, Courtney hit it right on the spot. This patient was taking Mounjaro. So that's tirzepatide. It's a GLP1 receptor agonist and also a GIP receptor agonist. And since it's been a while since we were all in med school, those stand for glucagon-like peptide 1 and then glucose-dependent insulinotropic polypeptide. So it's in a similar-ish category as semaglutide or Ozempic. That one is specifically a GLP1 receptor agonist only. So it can be used certainly with diabetes, but we've seen a lot more frequently people have been using it for weight loss. So it's been a very kind of common medication people have been trying to use a little bit more. So Mounjaro.
Kim, in her medical history, it just says migraines.
Yeah. Mm-hmm.
So why is she on Mounjaro?
That's a good question for weight.
Because those are risk factors for NAION.
Yeah.
Themselves.
Right.
Mm-hmm.
But yeah, she's on it just for weight.
I don't know what her specific weight was. I don't know, Dr. Corn, do you remember? Was she particularly heavy set?
I'm not like, if I was a carnival, I'd be able to get better. She probably was about 160, maybe 170.
Okay.
She wasn't, but she wasn't small.
Okay.
Yeah. I thought she looked pretty good.
Yeah, and we know a lot of people don't, disclose like, oh, I have obesity or I'm taking this for obesity, but they'll say what medications they're on. So you'll ask them
one of those
high blood pressure. They'll say
It's
no.
a classic question, like in a relationship, when your spouse asks you, do I look like I've lost weight? Like, there's no right answer. Because you can't say yes, because it implies that they had a weight problem. And you can't say no, because it means that they're not successful. So you just have to smile and say you look good. Just a little clue for keeping the relationship going.
Life lessons from Dr. Cohen.
That's like one of the top relationship.
Learning.
It's marriage advice.
It's a good plan.
So these next two articles, Dr. Cohen actually showed them to Kevin and I. So the first one is an article, a study done and published with JAMA. So it was a retrospective cohort study at a single institution, and it evaluated the incidence of NAION in patients with DM2 or those who are overweight, obese, that were either prescribed semaglutide or a non-GLP1 receptor agonist anti-diabetic medication. So the results are patients with type 2 diabetes, and the amount of patients was about 700 for this group. The incidence of NAION was 17 in the semaglutide group, and then 6 in the non-GLP1 receptor agonist group. The cumulative incidence of NAION over the 3-year period was about 9% in the semaglutide group and 1.8% in the non-GLP1 receptor agonist group. So definitely more common in the semaglutide group. In terms of the patient group, for those who were overweight, obese, the NAION events were 20 in the semaglutide group and 3 in the non-GLP1 receptor agonist group. Cumulative incidence for the 3-year period, 6.7 versus 0.8 for the semaglutide versus the non-GLP1 receptor agonist groups. So this study did suggest an association between NAION and semaglutide. Of course, you can't say whether it caused it or not based on a retrospective cohort study. And it would be hard to say anything caused it. So the next study actually doesn't show this association. So this study was published in AAO, and it was a multi-institutional review, and it was done in multiple different countries, but specifically looked at only white patients. So for this study, they looked at either patients with DM2, obesity, or both, and seeing the incidence of NAION. And they ultimately found that either at the 1-year, 2-year, and 3-year kind of analyses that there was no association between semaglutide and NAION, and they suggested that if the medication was recommended for or recommended by the physician for anti-diabetic care, the risks of the medication were lower than the risks associated with diabetic complications. But for patients taking the medication just for weight loss, it's a different discussion. So I think the jury is still up for debate, but probably not the best medication to be on if you have a history of NAION, for example, in one eye. So it's interesting articles. And
Yeah, so it's so hard to answer questions. You can't do prospective randomized studies. You just can't on most things. So this is like two angles, and the Harvard, I think that first study was a Mass Pioneer study, I think, and they were they said in their discussion they had very good data. So they had like really good. The patients had what they thought they had. All the charts were very good, and they felt like that was the best way to do it. But then on the other side, what you see a lot of times nowadays are these giant data studies, like sometimes a whole country. You'll see like France or Australia, like everybody in the country is in the database. But the database studies the data's not as good, like somebody might have coded wrong. It picks up patients that don't actually have it. So there's this tension in the data science about and this was interesting because let me see, there are many clinics they're saying a lot of people are getting these medications. So it's an interesting thing, and it's one of those things you might never get an answer to. I just saw recently in the news, there's lawsuits starting to pop up on people with vision loss and GLP-1 inhibitors. Just the last couple of weeks. But I would say, and we have the same thing with anti-VEGFs. There's the stroke thing. What do you do with that? I was in a room with a bunch of retina people, like, what do you do? And there's no good answer because the big data, more and more studies show that there's no real association between intraocular anti-VEGFs and stroke. The clinical trials show it, the Medicare database shows it, but then there's some small things that say, well, there may be, if you do it systemically, there's an association, so what do you do? it's hard to know.
It's the old autism and vaccine
Right,
issue, isn't it?
yeah, it pops up and it's hard to know. But anyway, this was interesting. And actually, Kevin was working on this and then the other, this paper just got published last month, I think. And so I said, oh, you gotta include this one. Thanks for doing it, Ken.
Sure.